Welcome to the Shift Report, the podcast from MCentric and the MCentric Foundation. MCentric is the go-to information and resources hub designed exclusively for the emergency medicine community. We regularly host key leaders from the field who share their insights and experience. Our goal is to inform our listeners and to encourage you to use what you learn to improve your practice and improve yourself. To learn more, please visit us at mcentric.org. Today's episode is sponsored by Lotus Clinician Wellbeing. Lotus Clinician Wellbeing provides consulting services designed to prioritize clinician wellness in order to provide the best care for their patients. Lotus Clinician Wellbeing supports healthcare professionals with personalized coaching and consulting services for groups and individuals in areas such as career development, leadership, burnout prevention, practice management, and more. For more information, visit lotusclinicianwellbeing.com. Today, we welcome Jesse Pines. Dr. Pines lives and works in the Washington, D.C. area. He's well known for his extensive set of publications on clinical quality, healthcare financing, and a host of other issues. Today, he joins us to focus on what we all need to know about health insurance and the financial system upon which we all depend. Welcome, Jesse.
Yeah, thanks for having me.
Thanks for taking the time to chat. You and I have known each other a long time, and many people in emergency medicine, if they don't know you, have read your work, largely focused on the business of emergency medicine, which sometimes is a bit of a dirty word, but in fact is what we need to know about and understand because it's our livelihood and it's how the system works and it's actually how patients get access to the system also. And so a lot of the sometimes difficult to understand concepts are really fundamental to what we do. And so I appreciate the time you've spent learning about them and educating all of us about them. As we start, you're practicing emergency medicine and have in a number of places. How did you get your start in emergency medicine?
But thanks for asking that. So I was an undergrad at Penn many years ago, majored in the biological basic behavior, spent a year between college and med school, and had a variety of different experiences. I was taught on a marine biology program for the summer, and then ended up having two very interesting experiences. I worked for Senator Joe Lieberman, and then I was a White House intern, in the same class as the most famous White House intern that everyone knows, Monica Lewinsky, and actually did know her. So definitely everything that happened at that time brings back a lot of memories. I also worked for a pharma company before for the last few months before starting med school, which I did at Georgetown. And really sort of early on, I developed an interest in the business of medicine, and applied to the MD MBA program when I was a first year med student. And it was actually the second year the program was going on. And my interest at the time was that I was going to get into biotech or be a consultant or do something in finance. And I worked for the summer with a guy named Kevin Schulman, who is a MD MBA from Wharton back in the 80s, health services researcher. And we basically worked on a study together, an economic analysis of bone marrow transplant, a bone marrow transplant intervention. So that was sort of my early experience with both business and research. And I finished the MD MBA program in 2001. And if I had finished in 2000, I probably would have gone out, done an internship, and then gone directly into business. But 2001 was many economic downturns ago. And I thought that, maybe I will go out and really become a practicing physician and then sort of divert into some of these other areas, and found emergency medicine as something that I really I loved my shifts. I loved working there. It was always exciting, fun. I loved the staff, environment, patients. And it was something that allowed me to partition my life in such a way where I could do emergency medicine and other things. So that was really how I got my start. I went from Georgetown directly into residency at University of Virginia, and then took off from there.
It's interesting. There are many people who are looking to do other things, and people, whether you call them side gigs or other things or non-clinical work, it sounds like you were kind of aimed at that, and then diverted back to clinical medicine because of enjoying it. And there was an economic downturn involved also, but enjoying the clinical work, which I think is important to all of us. Over the years, you've continued to pursue that business aspect. And rather than recounting all the voluminous articles you've written, and people can search your name in various databases and find a wealth of information about insurance. Tell us a bit about, in a few minutes, you could probably go on for hours and still not cover everything, but our healthcare financing system, I think, at least I have said, and we would agree, if you were designing it de novo, it would not be designed the way it is now. But we have what we have. What do we need to know? What does the typical resident or early attending need to know about how insurance works, how their financing works, both the private insurance world and the public world of Medicare and Medicaid? I realize that's a huge question.
Sure. So let me sort of break that down in the context of how we get paid as emergency physicians. So a patient comes into the emergency department. Um, Unlike pretty much any other country in the U.S. in the world, despite not being guaranteed payment for seeing that patient, we as emergency physicians need to see every patient regardless of whether they can pay, and that was enacted in the 80s. So patients come in, they either have insurance or they don't have insurance. We have to see them regardless. However, among those that do have insurance, physician and the hospital will get paid variable amounts of money based on the insurance the patient has and what happens to them in the emergency department. And that basically sort of breaks down into the fees that are paid to the emergency physician, which is called the provider fees, which includes basically for the visit, and then for any procedures that were done. And then you have the facility fee, which is the amount that's paid to the hospital. Now, for people who have government insurance, which include Medicare and Medicaid primarily, there's really sort of a fixed amount of money that legislatively is given to the physician group or the hospital or whoever is employing the physician for treating that patient. However, when it comes to private insurance, that's where the amounts can really vary a whole lot. And the amount that the physician group gets paid based on private insurance is based on a negotiated agreement between the physician group and the and or hospital and that private insurance company. And the amounts that get paid to the physician vary tremendously for the same service. And it's similar to, you're on a United Airlines flight and everyone is sitting on the same airplane and going to the same place, but people pay remarkably different fees based on whether or not they're sitting in, first class economy, where they're sitting on the plane, but also, sort of when they bought the ticket, whether or not they use miles, et cetera. So it's really similar in hospitals. So, the same patient with the heart attack, with private insurance or public insurance or uninsured, the amount that the physician group and or hospital is going to get paid is widely different for basically the same care. And what happens then is creates a system where the let's say take a physician group needs to survive, and the primary expenditure for a physician group is going to be paying physician salaries. So in the end, you have to bring enough money in to pay those salaries, administrative costs, malpractice insurance, et cetera, all the various costs. When you look at the amount of money that comes from private insurance versus the public insurance versus the uninsured, it's basically a rob Peter to pay Paul situation where the amount that comes in for private insurance is very high relative to what it costs to take care of the patient, and then for public insurance, in particular for Medicaid, that amount really flips, where it costs more to have the physician there taking care of the marginal Medicaid patient than the physician group gets paid. So that's really the basic economics of a physician practice that I think people should understand.
Yeah, and I think your point about private insurance versus Medicare and Medicaid and the reimbursement is an important one because there is, the system is set up this way. And Medicare, we hear about Medicare reducing fees paid to physicians, and we hear about this almost every year. What can you tell us about how that works and the impact that has on us, and maybe what we can do about it, if anything?
So, so basically, the amount that a physician group gets paid for a Medicaid for a Medicare patient is based on a number of different things. One is the amount of what's called relative value units that go into each visit. Now, relative value units are quantified based on the primary one is going to be the visit itself, and then you also may get relative value units for things like procedures. Let's say you drain an abscess, and there may be some additional what are called RVUs associated with that. The government legislates the amount of dollars that's paid for each RVU, not just for emergency medicine, but for the entire Medicare program. Now, a separate group, the what's called the AMA Resource Utilization Committee, decides among all the different specialties what are each of the procedures and clinic visits worth in terms of RVUs, but the government decides how much each RVU gets paid. So that's basically a congressional decision that's decided every year in terms of what we actually get paid. The problem is that among the various stakeholders in medicine, you have, let's say, just take two. You've got hospitals versus physicians. Physicians have historically had less ability to advocate for sort of higher, more and more payments for RVUs to basically keep up with inflation over the years. So what's basically happened over time is the inflation adjusted amount that we were getting, let's say 10 or 15 years ago compared to 2024 and even 2025 is significantly less. Historically, what's happened, healthcare costs have been, an issue for a very long time. You read a standard, health econ paper from the last 20 years, and the first line of the paper is that healthcare costs continue to increase, outpacing the growth of inflation, and are now worth X percentage of the GDP. 17, 18, 19%, 20%, whatever it is. So a major focus of the government, it has been to how do they reduce healthcare costs. In order to do that, I don't want to say an easy way, but a way that they've got good control over is to basically control what the amount of dollars that are paid into the Medicare program. And physicians, because we are in guilds rather than, being all grouped together and, everyone being a member of the AMA. Only 10% of physicians are members of the AMA, which does advocate, but has fewer resources than, let's say, the American Hospital Association to advocate for increased payments over time. So we've been increasingly marginalized over time. I don't see that changing soon with the current system.
Yeah, the advocacy is important. And you having grown up professionally in and around Washington, you see this locally and what advocacy can do in various industries. And your point is well taken that physicians are not a particularly together group as opposed to hospitals or others. And so many other industries, whether it be hospitals or insurance companies or oil companies or any other industry, put their resources together and lobby for themselves. And physicians, you're right, have not been very good at that. So one issue, and there are lots of issues, and thank you for making a complicated system understandable. Um, we heard in recent years about the No Surprises Act, which also a Washington thing. The names of acts frequently sound really good because people name them. But the No Surprises Act was aimed at a particular problem from a patient perspective that has significant effect on physicians and their payment. What was the No Surprises Act supposed to fix, and how has it worked?
So the issue that would happen before the No Surprises Act was implemented is that patients would get what's the insurance industry called a surprise bill. It basically would see, would get seen by a physician, be it an emergency physician, anesthesiologist, or another physician, and would get a bill that was much higher than they thought they were going to get. And the reason for that is because the physician group or hospital was out of network with their health insurance plan. And in the case of being out of network, what would happen is the insurance company would pay what's called an allowed amount, which is basically a small amount of money, and the rest of that bill, regardless of what was asked for, would get pushed onto the patient, and you'd get these news stories where you'd say, I went to the hospital, I needed 5 stitches, and I got a bill for $20,000. And people would say, geez, that doesn't make any sense. The issue was that not all physician groups were in network. So there were some situations, and hospitals were in network. So there were some situations where patients would get these unexpectedly high bills. Also it did actually benefit the insurance companies because they would actually pay a lower amount. The allowed amount is typically lower than the in-network rate, but essentially people would have these high bills, which really no one wanted. And the bill for $20,000 was not the physician bill. That was when a hospital is out of network, and that was basically for the hospital facility fee part of that ED visit. There was also a publication that came out. Now, I think this was 7, 8 years ago, that showed that some physician groups were actually going in and taking over, ED, in particular in the emergency department, taking over contracts and intentionally going out of network. Because what they thought was that, and what they found was that when they were at a network, the allowed amount plus the amount that the patient paid them for the provider fee was actually higher than the in-network rate that they were getting. So it basically favored ED groups to basically go out of network. So what the No Surprises Act did is it stopped all that, and
Mhm.
said that patients can know, we don't want the patient to be in the middle of this game between physician groups and hospitals and insurance companies and get these high bills. and basically said that, look, you really can't do that anymore. So then it sort of begs the question, how do you legislate this very complex business arrangement between a physician group and a hospital and an insurance company? And what the NSA did is it said, okay, look, we really want everyone to be a network, but if there is a situation where you can't agree on an in-network rate, then there's going to be an arbitration procedure that's going to happen. A neutral arbiter is going to come, and the physician group is going to say, this is what we think it should cost for the pay for the visit. This is what the payer says, and then we'll sort of pick, we'll sort of pick one or the other. The problem with the NSA has been sort of how it's been implemented, and this is where there's sort of what the law said, and then how the government has implemented it has really favored the health insurance companies. And we're not going to get into all the different details there, but the implementation has really favored the health insurance companies over time. But so on the good side, patients are not getting these large bills anymore, right? And that's a good thing. And that it's really created some, it really sort of leveraged the payer hand when it comes to the negotiations, because historically physician groups and hospitals have always been able to go out of network as a last resort. They said, look, we think this is what we should get paid for a level 5 visit. This is what you should get paid. Well, if you don't give us what we think, or you don't negotiate with us, we'll go out of network. You can't do that anymore. So it's basically tilted the ability of insurance companies in that negotiating relationship.
So yeah, a complicated issue, but I think it is, and it's one of those issues that, thank you for explaining it, that if you just look at the 1 or 2 sentence summary of it, wherever you might find it, it's really not enough to understand what the implications are. And so it's important to really read into the details. As I pointed out at the beginning, this we could speak about this very complicated subject that very few people understand very well, probably for hours. I do want to make sure we get to a patient flow issue. You've also written about um, patient flow and particularly boarding and boarding. We all know what boarding is. We all see it. None of us really like it. It's been documented that it's bad for patient care. It's certainly bad for physician wellness and burnout, because it's degrading to walk into a boarding situation. You wrote in 2010 as the lead author of a paper in Annals of Emergency Medicine, and I'll read the quote: dynamic inpatient bed management in inner city teaching hospitals in which non-ED admissions are occasionally reduced to ensure that EDs have reduced boarding times is a financially attractive strategy. In short, I take that to mean trying to get a hospital to reduce some of its elective and other admissions that don't come through the emergency department, in order to free up space to essentially open the back door of the emergency department and let patients go to beds in the hospital. But that can be financially good. I guess, can you give a little detail or explanation about how that might work? And where do we stand on boarding these days? And sort of what is your take on what, if anything, we can do about boarding, which remains a crisis?
So great question. And I was recently on an AHRQ panel, and one of the other folks on the panel was Gabe Kellen, who is the chairman of emergency medicine at Hopkins and has been there for a long time. And also Peter Bocelio is up there, Stony Brook. And they asked all the people, how long has boarding been a problem? And I can remember back to the very early 2000s. I was in med school, late 90s. I remember it was a problem then. Gabe mentioned the year 1982 when I was a fifth grader.
Mm-hmm.
As boarding was a problem back then, and it's a problem 42 years later. And the reason for that is boarding is a profit maximizing strategy for hospitals. and will continue to occur until it is no longer a profit maximizing strategy. And you say, why is it, why is creating a dysfunctional emergency department a profit maximizing strategy? And it comes down to basically two things. One is the amount of money and or sort of profit that a hospital gets from the average ED patient versus the average direct admission it is very different. So, your direct admissions are going to include patients who may have cancer, sort of transplant, and that really gets back to what I mentioned earlier, what's called the AMA Resource Utilization Committee, that basically allocates RVUs to different procedures. The surgeons and proceduralists have really sort of won out on that committee, and have been able to basically have the relative value of doing a procedure versus cognitive care is very much favors procedures. So if a hospital as sort of a standalone organization, you think of a hospital as a hotel, if you can fill that hotel with more patients who are paying for the more expensive rooms or have the more expensive procedures, or whatever it is, that's going to be the profit maximizing strategy. But really the way to do that is to first fill in with the profitable patients, and then basically use the emergency department as sort of a pop-off valve, where you still you need to have a emergency department that's open, for the community, and hospitals have just some hospitals just have decided it's good not to have an emergency department. Most have thankfully decided it's good to have an emergency department, because they want the ED to be open to the community and for when their patients have problems. But when the emergency department's used as a pop-off valve, you can still maximize the elective patients, and then boarding, which will fluctuate throughout the week. Several years ago, I did a study where we looked at the ED patients throughout the year, and then elective patients throughout the year. And essentially, what it looks like is it looks like VFib. If you track ED patients throughout a year, goes up and down, but is actually relatively stable, doesn't really move very much. It's actually very predictable, the number of patients who are going to come in on any given day in any specific hospital. When you track the number of elective patients, it basically looks like VTAC, with a period of asystole at Christmas time. That's really the issue, is especially early in the week, you've got the surgeons scheduling patients on Monday, Tuesday, and Wednesday. Emergency department becomes a holding area, because those elective patients will get preferentially placed in beds, and patients in the emergency department will wait. So that essentially, the only way that boarding is ever going to change is that if there's a change in the way that RVUs are allocated, or the government steps in and decides that boarding should no longer be the profit maximizing strategy.
So there's nothing like application of lethal arrhythmias as analysis of emergency department and hospital flow, and I think that a graphic I think we'd all like to see, and it makes perfect sense. And I think we've all experienced the Monday, Tuesday, Wednesday phenomenon of hospitals full, and you wonder what it's full of. Well, it's full of all the hips and knees and bypasses and everything else that are being scheduled, while the emergency department fills up on our busiest day of the week, Monday, which is everybody's busiest day of the week. And that's a great analysis. As we look toward, and we try to make this podcast as time independent as possible, but we can't help but notice that we are at least around the time of a transition of government at this point. And so for the next 4 years, there will be a new president and we don't know who the new HHS secretary is going to be, but there have been nominees, and there are nominees for other jobs too. If you had a crystal ball, realizing that also The government is a very large ship that is very difficult to turn quickly by anyone. What do you think? What do you see as the big issues for how the system works in the coming years?
So I think your last point is really important that, Trump is appointing or trying to appoint a number of people who are really going to try to disrupt the system. The question is, are those people going to be approved by the Senate? One, and if they do get in there, are they going to really be able to move the system in any meaningful way? And if I were to say, where things are going to go in the coming years, I think that there will be. If RFK does get in, his issues are, one around, reallocating how the, NIH may think about funding. That's certainly something within the scope of an HHS secretary. Moving some of the funding from acute disease to chronic disease. That's one area he's talked about. A second thing could be around the regulation of processed food, which is another area he's mentioned. You think about a lot of the food that we eat in this country is not allowed to be sold in Europe, because of a lot of the ingredients. That is certainly something within the power of an FDA commissioner to try to move, some of the policies there. When it comes to physician payment, when it comes to how insurance companies work, that is really, I think, an open question in terms of the types of things that the administration might do. Those things are very, very difficult to change, and as is the doing anything with processed food, or changing the funding in the at NIH. Because there are so many different advocacy organizations that have entrenched interests, and historically our country is basically guided by a lot of these entrenched interests, and who has a bigger say on Capitol Hill, or with the new administration, which is often guided by how much money they've given to the campaign, who they know, and how they can get specific individuals to prioritize their agendas. So I would say, if I had a crystal ball, I would say some things will happen. There could be some good things if there's, in particular, some movement into focusing on the things that actually do kill more Americans, things like, chronic disease that, we see every day in the emergency department. Maybe there'll be more funding around heart failure and diabetes, and the other stroke, and those common killers. And then but the broader question of whether or not there's going to be any major movement in sort of how physicians get paid, how hospitals get paid, and how insurance companies work. I think that's really an open question. And in particular, the latter area, in terms of how insurance companies work, there are some. I think a lot of things that the government could do to regulate specific programs. For example, there's an increasing percentage of the Medicare population that's in Medicare Advantage plans. The CMS can directly determine the rules of how those how what constitutes, when they decide to pay for inpatient admissions. What they pay for this, what they pay for that. CMS does have a lot of providence over that. So there are some possibilities about things changing there.
So that, great insights and tremendously complicated issues that you spent the early part of your career with a long career ahead of you to try to explain and to have us understand and to make the system work better. So we appreciate your work. How can we follow you, find out more about what you do, social media and otherwise? What's the best way to learn more about your insights on various platforms?
But thanks for asking that. So I still do a fair amount of publication. So still, there are some publications that are in the works with the USACS research group. We've got some very cool stuff coming out, so you can watch that come out. I also have a column at Forbes, and we'll be ramping that up next year, doing more columns. And then for the final area, I'm just putting the finishing touches on a book that I'm editing about measuring quality healthcare. It's called Quality Measurement in Healthcare, which I'm writing with Helen Burston and Jane Thorpe next year with Wiley. So those would be the three areas.
Wonderful. Thank you. And Dr. Pines, thanks very much for taking the time to speak with us today. But important insights and important lessons that we'll continue to learn as we follow you and your writing in Forbes and your books. Thank you very much.
Thanks for having me.
And thank you for joining us in this installment of our M-Centric podcast series, The Shift Report. And special thanks to Dr. Jesse Pines for sharing his important insights. For more content, networking, and innovation in the world of emergency medicine, please visit mcentric.org. And another thank you to our sponsor, Lotus Clinician Wellbeing. Learn more at lotusclinicianwellbeing.com.